Thank you for that introduction, Suzanne. Good day all, and thank you for attending this webinar. In this presentation, I will tell you about a SimSip application that has potential use to the clinician at the point of patient care. Physiologically based pharmacokinetic modeling, or PBPK modeling as it is commonly referred to, is well established for applications during drug development. It is now routinely used in those applications by the pharmaceutical industry, regulators, and researchers. In this presentation, you will see how PBPK modeling combined with Bayesian modeling was used to identify patients who have a high risk of developing serious adverse effects from a standard dose of the antiviral Efavirenz. Such patients usually require a decrease in dose for effective therapy. This work was first presented at the conference of the American Society of Clinical Pharmacology in Therapeutics in 2015. My co-worker Teresa Kane was responsible for the Bayesian analysis, but unfortunately was unable to join us today. I will start the talk with a very brief introduction to personalized dosing. I'll then talk about the need for personalized dosing with Efavirenz. We'll then move on to the methods used in our project to identify patients requiring the lower dose of Efavirenz. And following my discussion on results and performance of our study, I'll go on to discuss the potential application of this tool in the clinic. So that brings us to the question of why personalized dosing. In recent years, we have realized that with some drugs, a standard dose for all is not appropriate. The standard dose may result in poor efficacy in some patients or very high level of toxicity in others. This has led us to reconsider this old age concept of one size fits all. Drugs of particular interest are those that show a significant interpatient variability in either pharmacokinetics or response or both. Drugs with a high interpatient variability in pharmacokinetics that also have a narrow therapeutic range present us with special challenges when it comes to dosing. The pharmacogenetics era has enabled us to identify genetic differences in enzymes, transporters, and receptors, and this allows us to make informed decisions about dosage requirements in individual patients. Best practice in therapeutics now focuses on giving the right drug to the right patient in the right dose, as opposed to using the one-size-fits-all approach. Let's now talk a little bit about the Efavirenz and its variability. So as many of you would know, Efavirenz is a potent non-nucleoside reverse transcriptase inhibitor that is highly effective against the HIV-1 virus. It is used as first-line therapy and forms an important component of the highly active antiretroviral therapy, or commonly known as HAART. A standard dose of 600 milligrams daily of Efavirenz is normally prescribed. However, this is one of those drugs that displays very high inter-subject variability. This inter-subject variability in pharmacokinetics has been well studied, and as an example, Berger and co-workers looked at a cohort of about 250 patients on the standard dose of 600 milligrams of Efavirenz. They measured plasma concentrations that ranged from as low as below 1,000 nanograms per mole to higher than 10,000 nanograms per mole. And as you'll see, that's a huge range. About 78% of these patients were within the concentration range of 1,000 to 4,000 nanograms per mole, which is regarded as the therapeutic range. But the balance were mainly in the concentration range that was much higher than 4,000 nanograms per mole. This is problematic since concentrations above that range have been associated with serious adverse reactions, which then leads to treatment discontinuation. So before I go on further with elaborating on the kinds of adverse reactions, I'd like you to give us your ideas of what you would consider to be the most important source of pharmacokinetic variability with this particular drug. So you can tick the box that is most appropriate to you, and we'll have a look at it in a short while. Okay, so all of us are on the same page. We all believe that polymorphisms are likely to be the most important factor that influences the PK variability in Efavirenz. So about 50% of patients on a standard dose of Efavirenz experience neuropsychiatric side effects. These side effects can present as mild as headaches, dizziness, and anxiety, and they usually disappear with continued use of the drug. On the other hand, there are some patients that experience serious side effects, such as depression, confusion, and hallucinations. These lead to compliance failure or discontinuation of the drug by the clinician. The incidence of these serious side effects have been associated with plasma concentrations of about 4,000 nanograms per mole and higher. Many studies have focused on patient differences that lead to the significant difference in PK. And as you all rightfully stated, the CYP2B polymorphisms have emerged as the most important contributory factor. So CYP2B6 is the main enzyme that metabolizes Efavirenz, and polymorphisms in this enzyme system leads to significant differences in the rate of metabolism of the drug. And based on these studies, the extensive metabolizers of CYP2B6 may require a dose of about 600 milligrams daily, whereas the intermediate metabolizers and the poor metabolizers require a dosage reduction in order to get a similar exposure as the extensive metabolizers with 600 milligrams daily. So as you see from those observations, that in a poor metabolizer who is very likely to experience side effects from a dose of 600 milligrams, which is normally the standard dose, one really needs to reduce the dose tremendously in order to get effective and safe therapy. So based on those observations, some clinicians recommend genotype-guided dosing in these patients. The patients are genotyped. They're then classified as extensive metabolizers, intermediate metabolizers, or poor metabolizers, and based on that phenotypic status, they are given an appropriate dose. However, in the case of countries with limited resources, and as we all know, that those are the countries that generally use a great number of Efavirenz. In these countries, genotyping may not be readily available or affordable. And we were approached by a clinician in South Africa who asked us if there was some additional tool or other tool that can be used to identify patients who require the lower dose of the drug. This was an interesting challenge to us. Some evidence from the DESTA group of researchers suggests that Efavirenz can be used as a marker for CYP2B6 activity. And with that in mind, we asked the question, will a test dose of 600 milligrams enable us to identify poor metabolizers at the initiation of treatment? This was the proposed plan of action that we came up with. So we said we will use PBPK modeling to replicate a large number of subjects that would be EMs, IMs, and PMs. We would then simulate the concentration time profiles in those individuals and use that in our Bayesian modeling. The Bayesian modeling would be used to determine the probability of identifying a poor metabolizer by using a concentration of drug at a specific time. Once we've developed that model, we would then verify it by using clinically observed pairs for concentration and genotype. And of course, with that verification, the person doing the verification would be blinded to the genotype. They would just be given the concentration. And if all that worked, we would then have a tool that can be useful in the clinic. For those of you who are not too familiar with PBPK modeling, I thought that I should give you a little introduction, a very brief introduction to PBPK modeling. So the structure that you see on screen is a typical structure of a full PBPK model. PBPK model describes the behavior of drugs in the different body tissues. And depending on the route of administration, the course of the drug can be tracked through the blood and through each tissue into which the drug distributes. Each tissue is considered to be a physiological compartment, and the concentration of the drug in each of those compartments is determined by combining information on the system or the population that you're using, the properties of the drug that's being used, and the actual trial design. So these are the components that I've been talking about, the system data, the drug data, and the trial design. And this is how we can represent the systems approach to PBPK modeling. So the systems data involves your demographics, physiology, biochemistry, etc., regarding the individuals in the population that you are studying. The drug data involves things like the physical chemical properties of the data, the binding characteristics, the way it is metabolized, its solubility, and so on. And then, of course, the trial design involves the dose, the administration route, how frequently the dose is applied, whether it is administered with other drugs, and so on. So this information is then combined within the simulator, and using various algorithms, the PK and PD of the drug in the population of interest are predicted. The advantage of this systems approach is that changes can be made to any specific arm. So in other words, you can keep the drug data and the trial design constant, change the systems data, or you could change the drug and look at the behavior with the systems data being constant. As an example, you see, if we are looking at a population that has cirrhosis, and we're looking at a specific drug, we can then compare the behavior of the drug in your cirrhotic patient with the behavior of the drug in your obese patient, for instance. Or you could change the drug and see how different drugs behave in obese patients. And you can use various different populations. So you can look at things like ethnicity, age, and so forth. So as you see, it's a very good means of studying those individual characteristics of the population, the covariates in drugs, and so forth. So based on this system, it is very convenient to study which drug is the right drug, whether you have the right patient that's taking that drug, and of course the most appropriate dose that is required. And in this way, you are able to achieve personalized dosing. So with PBPK models, you are able to replicate patients, and these patients could be patients with different disease conditions, ethnicities, and so forth. And you're also able to replicate PK variability, such as variability associated with enzymes, transporters, phenotypes, drug interactions, and so forth. And as you see, these are the two areas that we are interested in when personalizing doses. So I'll now move on to the methods that we used in this particular study. For the Efavirenz PBPK model, we used the published model by Zhu and co-workers, and we used the Simcyp version 13. There were simulations of EM, IM, and PM patients on a dose of 600 milligrams. Once we did those simulations, we then verified the model using clinical data. So we had to recover the clinical data in order to ensure that the model that we're using was appropriate. So once we were satisfied that the model was acceptable, we then simulated concentration time profiles in 5,000 individuals in each of those groups. So you'll see from there that we had something like 15,000 individuals to be used as a training set for our Bayesian modeling. We then went further and isolated samples at 2 hours, 4 hours, 8 hours, 12 hours, and 24 hours. And the reason for this was to see if we could use any sparse sampling technique in order to get a high probability of identifying the poor metabolizers. In the clinic situation, it would not be practical for the clinician to present the Bayesian model with the whole concentration time profile. But if we could use one or two samples extracted at specific time periods, it would be much more practical. So with the Bayesian model, we use Bayes' theorem in order to calculate the probability of predicting a phenotype given a concentration at a particular sampling time. Once we identified the model that gave us the highest probability of predicting the poor metabolizers, we then had to check the reliability of those predictions. And in order to check the reliability, we used clinically observed pairs of concentration and phenotype. So Teresa, who was doing the analysis, was blinded to the phenotype. She was given the concentration and asked to test them in the Bayesian model. And the purpose of this was to calculate the probability of correctly predicting a phenotype, in other words, a true positive, as well as the probability of correctly rejecting each phenotype. So in other words, a true negative. These are some of the results that we obtained. So in these figures, you would see the PBPK model being verified. The figure on your top left are the extensive metabolizers, and there the red solid line represents the mean predicted plasma concentration time profile. The dashed red line represents the 95 and 5% percentile, and the dots represent clinically measured patient concentration. And as you'll see, there's a fairly good recovery of the clinical data. Similarly with intermediate metabolizers, which are on the top right-hand side, and the poor metabolizers, which are at the bottom. Using the concentration profiles that we've just seen, we also looked at the parameters associated with them, the PK parameters, that is the AUC, the Cmax, and the clearance. And we've compared the predicted parameters with those obtained in 2 other clinical studies. And there again, you'll see that there's a fairly good recovery of the observed data. And if you look at the AUC, you'll see that there's a significant difference between the EM, IM, and PM group. So this convinced us that our model was good enough, and that then motivated us to go on with the simulation of the 5,000 subjects in each case. These are the results from our Bayesian analysis. So the first important fact that emerged was that there was a high probability of predicting PM using a 24-hour sample after a single dose of Efavirenz. And this was very promising because in this case it's just a single sample that's giving you a high probability of predicting the PM. Then we went on to model verification. So on the table below, you'll see that we have true phenotype. True phenotype refers to the actual clinically diagnosed or measured phenotype. So these are the clinical data. Predicted phenotype would be that predicted using the model, the Bayesian model. And as you see, if you have a poor metabolizer, a true poor metabolizer, there's an 82% chance that the model would in fact predict that it's a poor metabolizer. We went on to further verification. In this case, we are looking at the probability of predicting a true positive or a true negative by phenotype. And there again, if you go to the last row, you'll see we have PMs in that row. And so there's an 82% probability that a true positive for the PM would be predicted, and an 87% probability that a negative would be rejected as a negative and not as a P. And we were very excited once we've seen these results. So as you will see, these results are very promising, and it suggests that there's a very high probability of us being able to identify poor metabolizers from just one blood sample after a test dose of efavirenz. The sparse sampling technique would be very attractive in the clinic because only one blood sample would be required. Our next step would be to use a larger clinical data set and confirm our findings. We had limited clinical data when we did the study, so we have to confirm this in a much larger study. And when we have confirmed this, we believe that this could be a very useful tool for clinicians to personalize efavirenz dosing. And similar principles can be used for other drugs that show similar characteristics. So how do we propose the use of this particular tool in the clinic? Essentially, what we think is that a patient would go into the clinic and be prescribed the standard 600 milligrams of efavirenz. The clinician would then ask the patient to come over 24 hours later and draw a blood sample. This blood sample would then be analyzed for efavirenz. The plasma concentration would then be used in the tool that has the Bayesian model. And depending on whether the patient is identified as a poor metabolizer or not, the clinician can make an appropriate decision on the dose selection for that patient. But of course, once that is done, we'd expect the clinician to do a plasma concentration at some stage just to ensure that that dose was in fact appropriate for the patient. And that brings me to the end of my talk. Thank you for listening, and it's question time.
Okay, wonderful. Thank you so much, Mano. We invite our audience now to participate in the Q&A session. Please submit your questions to Dr. Chetty through the Q&A box. Our first question from the audience is, do you expect this approach to work in the presence of polypharmacy?
The approach would work initially when initiating therapy, and if the drug is combined with other drugs that do not interact with it. So what we would say is that if there's drugs that interact with 2B6 or 3A4, there is a possibility that you would have to do plasma concentration monitoring to ensure that you are still in the ballpark range that you want to be.
Next question. Are there other polymorphisms that are relevant for efavirenz dosing?
There have been a number of studies that looked at polymorphisms or other polymorphisms of 2B6 as well as polymorphisms involving 2A6. And a number of little studies have suggested that there are other polymorphisms that could be involved as well. But the net effect of those polymorphisms would be on either causing the patient to be a poor metabolizer or not. So if one does the genotyping for 2B6, it seems to be adequate at this stage.
Would therapeutic drug monitoring be useful for efavirenz therapy?
Yes, definitely. There are many groups of people that are looking at therapeutic drug monitoring for efavirenz, and this becomes especially important if you're using the drug in combination with other drugs. Now, as you know, with the efavirenz therapy, it's often combined with other HIV agents, as well as people with HIV infections may also have TB and other disease conditions. So because of the polypharmacy, therapeutic drug monitoring could be a very important tool.
How well established is the concentration-effect relationship with regards to antiviral effects as well as CNS side effects?
There's two schools of thought regarding this so-called therapeutic range. So some people believe that the concentrations may not be a true reflection or a true therapeutic range, whereas others believe that it could be used as a fairly good marker in order to aim your therapy. So the upper end, some believe that the upper end of 4,000 micrograms per liter might be too high because side effects are seen at a slightly lower concentration. But I think it's a question of individual variability as well. And for now, most people seem to use that 1,000 nanograms per mole to 4,000 as a rough indicator or rough guideline for treatment.
Someone from our audience would like you to talk a bit about using the model to identify intermediate metabolizer patients.
In this particular study, using the 24-hour sample, that is, while we got very good probability of identifying poor metabolizers, the intermediate metabolizers could not be differentiated from the extensive or the poor metabolizers to any significant rate. So in order to identify those intermediate metabolizers using this approach, we may need more plasma samples. So the one sample may not be effective for that purpose.
Someone would like to know whether this problem could be addressed with a PBPK approach, or whether that approach has already been used for this problem.
There have been a number of PBPK studies that have been done to identify covariates that impact on variability. Also, there's been one study that has looked at whether giving a 400 milligram dose and a 600 milligram dose has any major effect in terms of the pharmacodynamics of the efficacy of the drug. I think this approach is basically saying that if you have one plasma concentration, and that plasma concentration is obtained at the 24-hour post-dosing, then that can just be used in a little app. Eventually, one could use this as a little app. And the physician or the clinician could plug in that concentration and by that identify whether you have a PM or not. Hopefully down the line it would be as easy as plugging a plasma concentration into an app.
If the true positive and true negative probability values are 0.82 and 0.87 for poor metabolizers, what will be the conclusion for subjects considered or identified as poor metabolizers?
Well, if they are identified as poor metabolizers, it then means that they are likely to experience excessively high concentrations on the standard dose of 600 milligrams. So one would then want to reduce dose in those patients. I guess that's the primary aim of the study, where you want to identify those poor metabolizers, and that will give you an indication that those patients require a reduced dose. In South Africa, for instance, we were told by clinicians that if they prescribe the standard 600 milligram dose and patients take that dose and go off, they may then experience those serious side effects, and if they do, they never return to the clinic. So hopefully, if you can identify such patients at an early stage and prescribe a lower dose, you would not get them defaulting from returning to the clinic.
Someone would like you to discuss a little bit in your confidence on the abundance of CYP2B6 for extensive metabolizers, intermediate metabolizers, and poor metabolizers?
Well, that, I think, varies from varies within population groups. And there's been a lot of research around what the abundances are and what the different frequencies are in terms of the different types of metabolizers or different genotypes. At this stage in the simulator, we have information that best relates to the current literature. And if at a later stage additional information becomes available, then we can update that information. But
there's a question.
We have simulator. Sorry, Suzanne?
Yeah, no worries. We have a question of whether you modeled Efavirenz-induced CYP2B6 induction, and if so, what data did you use in order to do this?
Okay. This particular study involved a single dose, so the model does not have to have induction since we're using a single dose. But in the simulator, we now have a Efavirenz model that does have autoinduction for CYP3A4 as well as CYP2B6. And that paper has just been published, well, it's about to be published in CPT PSP. It's Dr. Alice Key's paper. That should be out there soon.
This looks to be the last question from our audience. Someone asks, when a sample is collected, after a sample is collected, will the patient's specific demographic information be considered when determining their probability of being a poor metabolizer using PBPK, which is structured to take advantage of such information?
No. What the initial phase of the model, the Bayesian model, considered a high number of variables in terms of patient population. That is the model that used the 5,000 patients with each genotype. In this particular situation where we're saying at the clinic you use just one sample, that won't take into consideration the patient demographics. It's basically matching the plasma concentration and using that to try and predict the genotype.